So before we go on to the cruciate ligaments, there is not much in the anatomy, so I'll explain directly over here on the cases. So let's look at case 1. Now this is a slightly longer case. I'm going to start from lateral to medial. All right. So what do you see? Anterolateral femoral edema, posterolateral tibial edema. There is fibular head edema. There is some fibular fracture over here. Okay. Now as I go inside, you can see that there is a complete tear of the proximal third fibers of anterior cruciate ligament. Okay. If I go further medially, there is a posteromedial tibial edema with a subchondral fracture. So, main pathology, this is a pivot shift injury edema pattern. All of you know that. I'm sure most of you know that. And therefore, obviously, this patient, inconsistent with the edema pattern, has a full thickness ACL tear. Now, let's look at the other structures. What is the status of PCL? Even PCL is showing some signal. The part of it is black in color, part of it has become gray in color. So, let's look on the axial images. So, you can see how the PCL is looking on axial over here. There is hyperintense signal. There is black signal here and there is hyperintense signal here. So it is involving approximately 50% thickness of the PCL. So the point that I want to put forth is whether it's a PCL tear or a ACL tear, if it's a partial tear, always put a habit to look at the axial images. That will give you the best knowledge, how much thickness it's involved, whether it's a single bundle injury or not. You will not require the oblique sagittal images for ACL if you put a habit of looking at the ligaments in all three planes. I never take a separate T2 sagittal oblique for the ACLs. We don't do it, right? Because I have a habit of looking in all three planes. So make sure that you develop that habit early on. So this is the PCL injury. Besides that, what else do we have? There is also a lot of signal in the anterior fibers of MCL. So obviously there was a medial collateral ligament injury. We've recently discussed meniscus. So let's look what's happening with the meniscus over here. So you can see there is a nice bright signal that is going between the meniscus and the capsule. So this is a ramp lesion. Okay, I'm good. Everybody is identifying. I'm very happy. So, okay. Then what's happening with the lateral meniscus now? Anybody? Anything is happening? Okay. So this is again a Risberg rib tear. Now if I'll come here, I don't know how much well it is visible on this actual images. But you can see that this particular signal is almost extending till this level. Okay? The root is over here. So it is almost up to the mid part. Right? So this is I'll put a better PD image for you to understand. So here you can see this is a Risberg rib tear. It's a peripheral longitudinal tear that is extending up to the inferior surface, even superior surface. So this is nothing but a Risberg rib tear of the lateral meniscus. Okay, so we've seen the meniscal tears, we've looked at the collaterals. The last thing I wanted to show you, which is not a part of this, but a part of cruciate ligament injuries is, you can see this structure, this is your posterior oblique ligament. So there is a ramp lesion, there is a posterior oblique ligament injury, which means that there is a posteromedial corner injury. What's happening on the lateral side? You can see that there is a small fracture here. I hope everybody can appreciate this small piece now. You can see the cortex. This is a Segon fracture. Very difficult to see on MRI, particularly when there is edema. Very easy to see on a radiograph. So always ACL injuries, please take the radiograph. Your half of the problems will be solved. Okay, so this is a Segon fracture over here. And you can see this area, all this area where there is a hyperintense signal, this is a part of arcuate ligament complex. So let's look at the posterolateral capsule as well. So here, this is the posterolateral capsule. You can see that it's appearing fuzzy. There is a lot of edema. So there is a posterolateral capsular injury as well. All right. So this is a patient with full ACL tear, intermediate grade PCL injury, MCL and LCL injuries, both meniscal tears, posteromedial corner injury, posterolateral corner injury and Segon fracture. Unfortunately, kuch nahi bacha uska. Right? So very easy if you know everything. This is the checklist that should run in your mind whenever there is an ACL injury. You have to go through all these stuffs. Okay, so let's look at the second case. Okay, same again, posteromedial tibial marrow edema, anterolateral femoral posterolateral tibial marrow edema. This means that this patient has some form of ACL injury. Now what is that injury? It's basically a avulsion fracture. Even avulsion fractures can be very slender, subtle, often difficult to see. But remember, distal tibial attachment ACL tears are very, very rare. So if you see a distal attachment tibial tears and you cannot identify the osseous fragment on an MRI, either look at the radiograph or get a CT. It will most likely be an avulsion fracture rather than just a tear of the ligament. Okay, so here you can see that this is an avulsion fracture. In an avulsion fracture, you need to mention the fragments. So this is a fragmented, there is one piece here, one piece here. Either you can give a complete dimension or you can give the dimension of the largest fragment. But more importantly, you have to mention how much is the superior displacement. If it's not displaced, they may still not fix it back, particularly for posterior cruciate ligaments. They don't fix it back if it's not much displaced. But if it is displaced by 4, 5, 6 millimeters, then they want to fix it back. So you need to mention the size, so that if whether the screw can hold the fragment or not, and how much is the superior displacement. Added to that, you can see that there is an injury in the distal third fibers of the ACL as well. So now with this, we'll go back to the PowerPoint. Okay. So we've seen the first and second case. The mechanism of injury is a non-contact or a direct contact injury. What happens is the femur just twists over the tibia, right? This is called as the pivot shift injury. So this is what actually happens. There is anterior translation and the posterior tibia hits against the anterior aspect of femur, and that's why you get this classical edema pattern. Anterolateral femur, posterolateral tibia, peripheral medial femoral, posterior medial tibia, right? So this is a classical pivot shift pattern. Now we've seen impaction injury of sulcus terminalis, marrow edema. But the most important thing is ACL itself. So you can have a complete tear, partial tear, single bundle, or osseous avulsion. Whenever you report, you need to mention what exactly is the site of injury, whether it's femoral attachment, mid fibers, tibial attachment, and what is the grade of injury, how much thickness of the fibers is involved, or whether it's a single bundle injury. You need to mention that. So here this is a full thickness femoral attachment tear, full thickness proximal third, mid substance, osseous avulsion, very well seen on the X-ray as well, right? So this is the whole spectrum of different locations, and then you can have a full thickness, a partial thickness, and a single bundle. Now if you'll see partial thickness and single bundle on a sagittal, I can't differentiate the two. For me, even the single bundle is like a partial thickness tear. Look at the axial. The partial thickness, you can see that it's involving both the bundles, but here you can see the anteromedial bundle is intact, whereas the posterolateral bundle is involved. So that's why I'm telling you, always, always, always make it a habit to look at the axial images for your cruciate ligament injuries. You'll get a lot of information from that. Then you look for other things which we've already seen, Sagon fracture. Arcuate fracture is a fibular styloid process avulsion fracture, which are again are very small, difficult to pick up on MR, very easily picked up on a radiograph, right? So arcuate fractures, corner injuries, meniscal injuries, collateral ligament injuries. All these checklists should just run in your mind one after the other whenever you look at AC ligament injury. Sorry, let's go on to the third case now. Yeah. So I'm just going to show you. So basically, you can see there is some signal in the PCL. Now remember, posterior cruciate ligament is a tightly bound collagenous ligament. It is completely black in color. Any signal in the PCL is abnormal. You need to look what exactly is happening with the PCL, right? So there is some bright signal over here. So it looks like there is some injury. But now let's look at the axial images and what do we get. So this is the PCL, right? And what do you see? You can see that this bundle, which is on the lateral side. So always remember, for ACL, I just remember the term ample. A-M-P-L-E, ample for ACL. So AM is anteromedial, PL is posterolateral. So this is ACL. PCL is exactly opposite. If it's anteromedial there, it will be posteromedial here. If it's posterolateral there, it will be anterolateral here. Right? So this is the anterolateral bundle and this is the posteromedial bundle. And what is happening? Only the posteromedial bundle is injured. So this is a single bundle injury involving the upper or the proximal and mid-third fibers of the PCL. The tibial attachment looks intact. Okay, so it's something like a low to intermediate single bundle injury, but you will never pick up a single bundle injury if you don't look at axial images. So with this, let's go on and just a couple of slides for the PCL. So here, So posterior cruciate ligament injuries can be of more commonly two types. Either it's a dashboard injury, which commonly happens in car crashes, where it is just the edema pattern you'll find only in tibia, or it's a hyperextension injury. What happens in hyperextension? You will get kissing contusions. So basically you will get edema in the anterior femur and anterior tibia, which is nothing but the kissing contusion, which happened when there was an episode of hyperextension. We've seen the marrow edema pattern. Again, the ligaments. Remember, ACL and PCL is pretty much the same. There is not much difference between the two. So you'll have a low-grade injury where there is just some signal in the ligament. High-grade injury where some fibers are intact, but more than 75% of the fibers are torn. A full thickness tear. And then you can have a single bundle injury, which you will only appreciate on the axial images. And lastly, you have the osseous avulsion fracture. So again, you need to give the size, you need to give how much is the superior subluxation. More than 6 or more than 6 millimeters is usually when they want to fix it back. Okay. This is a whole spectrum. And now lastly, I'm going to the last case. So thankfully, I'm on time. So this is a case where I have a follow-up. So I'm just going to show you the dates over here. I hope it's visible. So this is from 30th September and this is from 21st November. So there is about 6 weeks gapping between the two scans. So now let's look at the first scan, which happened when the patient developed injury. So seeing this, okay, now I want all of you to tell me what is there. Sorry, A or P? Okay. So you also have the pivot shift edema pattern. And obviously there is a nice ACL injury. Usually when it's an acute stage, the orthopods will not immediately operate. The patient will rest for 4 to 6 weeks. If still there is Lachman instability and the patient, if he wants to repeat the scan, he'll repeat the scan. So this is what happened. After 6 weeks, the patient came back. And now this is the status of the ligament. So you can see there is a discrete tear here visible, which is not very much visible over here, but does it look like a normal ligament? No, it does not. Better seen on the PD image. So now let me just open PD images from both the dates for you. So here, this is where there was the injury, okay? So you can see that there was disruption of the fibers here. But look at this ligament. It has tried to heal, but it has been completely unsuccessful in doing so, right? So you can see how the ligament is looking. Practically, you can't appreciate any internal fibers. It's just a gray band that is going and attaching the two bones. So this is nothing but a poorly remodeled ligament or a poorly healed ligament, right? So now let's just have a couple of discussions or slides on the remodeling of the ligaments. So, okay. So in chronic injuries, you want to look for other signs to just help you. If, there will be remodeled medial collateral ligament, there will be a sulcus terminalis depression, there will be a predominantly lateral compartment OA because of ACL instability. So look for all those findings and look for the ACL itself. So either it can be a remodeled or sometimes you won't find any ACL when it's a very chronic injury. So this is a poorly remodeled ACL where you can see that we cannot identify any ligament fibers. This is partially remodeled where some fibers are visible, but still it is not normal looking ACL. And then this is no ACL. Practically the notch has only one structure, which is the posterior cruciate ligament. I can't see even the PCL much. So even the PCL probably was damaged in this patient, right? So these are the three things that you can see. Now often people ask me how to differentiate between a poorly remodeled ACL and a mucoid degeneration. One, look at the other things. Are there other signs of prior injury? Is there a remodeled MCL? Is there a remodeled lateral collateral ligament? Is there a meniscal tear? Was there a ramp lesion? Is there a scarring in the meniscocapsular junction? So look at all of those things. Or whether it's a predominantly medial compartment OA with horizontal tear. That will make it in the favor of mucoid degeneration of the ACL. Looking at the ACL, a poorly remodeled is a very fuzzy looking ACL. Whereas in mucoid degeneration, you can actually draw the individual ligament fibers. So if you take a pen and you start drawing, you will be able to draw. Why? Because this is where the mucoid material is going between the fibers. The fibers itself are not damaged, right? It's just a swollen ligament. In poorly remodeled, it's a torn, damaged fibers, right? So take home points, look at the ligaments in all three planes, look out for edema pattern. Edema pattern will give you the maximum idea. Chronic conditions, look for sulcus terminalis depression, subchondral fractures and other stuff. Look for other ancillary findings and other soft tissue injuries. Radiographs will be your real friends, particularly for tiny fractures. So please make sure to look at the radiographs. Make it a habit from now on so that it stays for life. Talk to the orthopod. If you're stuck, you don't know whether this is still mucoid or partially remodeled, just call up and ask the patient, did you have an injury before? Or talk to the orthopedic surgeon, is the patient having a ligament laxity? And look at the previous imaging. That's it. Thank you.